Good evening, everyone, and welcome to the very first episode of LitEM, Learnings, Insights, and Trends in Emergency Medicine. My name is Apoorva Chandra, and I'm the head of the Emergency Department of Emergency Medicine at one of the units of Star Hospitals in Hyderabad, India. Before we begin, I think I have to admit, with Scott Weingart being here, I'm having a bit of fanboy moment for sure. To explain that, let me just start with a 1 minute flashback. So one of my closest friends and residency colleagues by name Dr. Lakshay Chanana introduced me to this world of podcasts, critical appraisal, following the evidence, and questioning the established practice during EM residency. So I still remember how these podcasts, format, and the dogma lysis based on the new evidence started influencing the way I thought about medicine. What started off as a recommendation from a friend became a habit and eventually became a way of thinking for many of us in residency program. So a significant part of our residency learning wasn't just spent by reading textbooks, but it was also spent with earphones on, listening to EMCrit Podcast while traveling to work. We were also having conversations about these podcasts and the stuff we were reading online, kind of trying to make sense of why we do what we do. And at the center of most of these conversations was Scott Weingart. I remember listening to EMCrit episodes on topics like SCAPE, sympathetic crashing acute pulmonary edema, applying what I learned on it on the shop floor and realizing how much difference it created for the patient. Suddenly, we were looking at patients differently. We were asking different questions. We were managing some conditions very, very differently. It was one of the first times I saw how high quality evidence-based educational content could influence patient care in real time so rapidly. This shows how medicine advances not only through landmark trials and guidelines, but also through people who can translate evidence into practice and, more importantly, teach others how to think, not just what to think. And that's really, really powerful. And few people have done that more effectively than Dr. Scott Weingart. For most people here, I know that I don't think the name Scott Weingart would need any further formal introduction, but for the new residents and colleagues from other specialties, here is a brief intro. Dr. Weingart received his medical degree and completed a residency in emergency medicine at Mount Sinai School of Medicine. He then went on to do fellowships in trauma, surgical critical care, and ECMO at the Shock Trauma Center in Baltimore. He is currently an attending and a professor of emergency medicine at the Nassau University Medical Center, New York, and the director of clinical education and faculty development. In addition, Dr. Weingart is a physician coach concentrating on the promotion of optimal performance and eudaimonia. I know what you guys are thinking. I had to Google that last night as well, so you guys can do that once we finish the webinar. Eudaimonia, all right? Okay. Dr. Weingart is best known for his podcast on resuscitation and ED critical care called the EMCrit Podcast, and which has been downloaded more than 100 million times. Yes, you heard that right, 100 million times. Dr. Weingart, it's an absolute privilege to have you with us today. So I'll shut my mouth now. Dr. Weingart, probably you can start off by telling us briefly why you chose to talk about this trial in particular. And after that, in your signature style, I request you to please take us to the ANDROMEDA-SHOCK-2 trial. The floor is all yours.
All right. Thank you. Thank you for that introduction. I got to get over the blushing. You're too kind. And it's a great pleasure to be here, especially for the kickoff of this series. So thank you for inviting me, and thank you all for participating. Now, I thank you in advance for your participation. And that's really I'm imploring you to actually participate, because this won't be nearly as much fun if I'm sitting here lecturing. I could do that as a podcast, and then you could just listen to it on your way to work again. So this hopefully will be a discussion. That's what I've been promised, and I hope you all are willing, brave, and kind enough to do that, because then it could be a lot of fun. So why did I choose ANDROMEDA-SHOCK-2? I chose it because it is, I think, the trial most in the past 2 years that requires the treatment that I love. You see, we're doing ostensibly, this is akin to a journal club, but I don't like the evidence analysis. I don't like the methodology. I leave that to people smarter than me in those areas. I like the clinical translation to the bedside, and no trial requires more of a thoughtful process to know how to safely and effectively translate it to the bedside than ANDROMEDA-SHOCK-2. This trial, it's so much, there's a lot of stuff there. I think all of it is incredibly interesting, fascinating, worthy of discussion. And yet, each piece of it, really, you have to analyze and say, is this right for us at our shop or not? So I think it's going to be a fun discussion. The people involved in ANDROMEDA-SHOCK-2 are amazing, and what they pulled off with a very shoestring budget compared to some of these, mega trials that have enormous funding is amazing. And it's a testament to anywhere in the world. If you care about a clinical question, you can answer it. You shouldn't let funding be a barrier because you can get it done. And that's what the ANDROMEDA-SHOCK investigators really prove with this. Now, I said we weren't going to discuss methodology, but it just bears a couple of minutes of discussion because I don't want you to look at what we're going to say and say, oh my God, there's amazing evidence for any of this. Because this technically on paper, ANDROMEDA-SHOCK-2, which was a trial of using capillary refill time to determine a personalized hemodynamic optimization strategy for patients in septic shock. If you look at the trial, on paper, it's positive. But this is really a negative trial. And that's what I want you to understand. So everything we're going to talk about today, we're going to talk about it from a physiology. We're going to talk about it from a perspective of the other evidence that goes into it. And ANDROMEDA-SHOCK-2 is not proof of any of this per se. So really, we're going to be talking about it. Does this make sense for us to do without a great backing of evidence? Because ANDROMEDA-SHOCK-2, even though their endpoint, their composite endpoint, was positive, more patients did, as one of the pieces of the composite endpoint, normalize their capillary refill time. It's not the real outcomes we would have liked to see. We would have liked to see a mortality benefit. We would have liked to see, reduction in organ failure, all of the stuff that's really hard evidence. What we have really is a surrogate marker improving, and that's fine. Is what they determined before they started the trial. It's a objectively positive trial, but it's not positive in the way that makes me feel safe that anything we're going to talk about is definitive. But that being said, until definitive evidence comes out, we still got to treat patients at the bedside. And that's what EMCrit's all about, is figuring out what the hell to do with the evidence we have and then making it workable for us. So I think that's the intro I will say, and then I'll stop there and see if anyone has any points or questions before we actually delve into the clinical aspects of the trial. Does anyone want to comment? And Apoorva, how should we do this? Did people just open up their mics and speak? Do they put in the chat? What's the best way? How are we working this when people want to say something?
They can put in the chat box, but we can open up the mics as well. I'm just doing that at the moment.
Cool. All right. So I got no problem at any point if people interrupt me or just want to say, hey, wait, I don't understand this. I love that. Like I don't get frazzled by that kind of stuff. It just fuels me. So if you just want to shout out, I'm completely happy with that. All right. So I guess we'll start talking about what they did in the trial and then see for all of us, like, A, does it make sense? And B, does it make sense for our individual center to actually do any of this stuff? So they took patients who were in septic shock. So they all were on, vasopressors for septic shock. And they had lactates greater than 2, right, which makes the new sepsis 3 definition of severe sepsis, septic shock. That's what you need to get that. They were adult patients. I don't know anything about peds, so we're not going to talk about peds at all. And they had already done the macro hemodynamic initial optimization. So they had gotten their initial fluid bolus. Ostensibly, they had gotten source control. They had at least gotten antibiotics. Hopefully, if they had a surgical infection, then they're on the way to getting that taken care of. And they had been put on the vasopressors for that standard, bedrock map of 65 macro hemodynamic goal. And then they enter into a personalized hemodynamic optimization strategy, which is, really that's the dream in sepsis. And instead of having these things that are applicable to everyone, we are actually going to look at the individual patient's physiology at the moment and make a determination of what they need. So that's what we're trying to get here with the ANDROMEDA-SHOCK-2 protocol. And so the first thing they did is they checked the cap refill time. And if it was abnormal, then they're going to go further into the protocol. If it's normal, then they're going to monitor that patient, keep rechecking. So the first question we put to the group is, who is actually at this stage of the game using capillary refill time already to manage their patients. And do we have the ability to do like a survey, or is there any, like, I'm used to Zoom. I don't know if we have that capability in Teams, but like, is there a way to quickly know?
Not like a survey. I think either they'll have to put in the chat box or they'll have to switch on the mic.
All right, so we'll start the participation now. Everyone who is using cap refill time, put a thumbs up or some indication of that in the chat as I'm continuing the talk, just so we can get an idea. So if you're using it, put it there. We got 58 people, so we'll see how many come. Okay, so cap refill time, ANDROMEDA-SHOCK-1 had already established, I think pretty well, that trial I think was pretty definitively positive, that cap refill time is, people are doing thumbs up. Maybe that's what we do. Yeah, just do a thumbs up if you're using cap refill time. People in ANDROMEDA-SHOCK-1, that was better than a lactate strategy. All right, that was what they initially established. This cap refill time was at least as good, if not better, than a lactate trending protocol for managing septic patients. So we probably should have already been using cap refill time before ANDROMEDA-SHOCK-2 came out. Now, it's worth stating, I think you got to be pretty particular about how you're doing cap refill time. All right. What they did in the trial is they took a microscope slide, right, like a piece of glass, and they put it up against, the index finger or the middle finger. I believe they specified index finger, if I remember correctly. And they blanched the finger till it turned white for 10 seconds. And then they let go and started a stopwatch. And as soon as the finger fully refilled back to pink, then they stopped the stopwatch. And if it was less than 3 seconds, normal rather, and greater than 3 seconds, abnormal. And
Seems like there is some tech interruption. Apologies for that. Hopefully we should be back soon.
all right, can you guys hear me? Yeah?
Yes.
All right, so my computer crashed. That's always fun. And so I'm on my phone right now. We'll see if I could get back to the nicer camera when the computer boots back up. But until then, we'll go with this. Okay, so that is a very particular way of doing this. Let's see, is my video on? There we go. Okay, it's a very particular way of doing this. And I think even if you're using cap refill time, but you're doing it by just squeezing it with your finger and then trying to guess if it's 3 seconds or not, it's not going to be translated to any form of reality. And that's been studied. So what you need to do is you need to actually, I don't think you need the microscope slide. That's a bridge too far. You need to squeeze the finger really hard so you're actually, fully blocking off all of the little vessels in there for 10 seconds. And then you need to use a stopwatch. You can't get away from a stopwatch. Now, it doesn't mean you need the thing that they have in track and field. You can use your phone. The problem is that the phone app, at least on the iPhones, I don't know if Android's any different. Like, you got to press a button that's the size of your thumb to start and stop. And the problem with that is, like, you miss, and then you screw up your measurements. So there is an app. You could go to the EMCrit site to find the actual link to the app that you can touch anywhere on the screen to start and stop. That's what you need. And that way you could actually, let go of the squeezing of the finger and then, immediately hit anywhere on the screen. And then as soon as the finger's pink, you hit it again. You don't have to look at the phone. And then you see, okay, less than 3 seconds or greater. So that is an incredibly easy to do at the bedside marker of something. So the question I'll put, and we'll see who's brave enough to answer, is what are you actually measuring? when you do a capillary refill time?
Perfusion is one of the answers.
Okay, I like perfusion. I'd like you to start, and this might be like what you take out of this session, of thinking about that in a really more zoomed in fashion. So, what perfusion are we really talking about? And thank you for whoever put that answer in. But I would love if people unmuted and actually we could get a conversation going, because it's not going to be as enjoyable for the next 30 minutes or so if we're just, me speaking. And so who's willing to unmute?
Well, we are probably talking about micro circulation perfusion, because that's what you're really looking at here.
Absolutely. That's fantastic. So that is a window, just as you say, into the microcirculation. But, and when you look at all their optimization steps, you'll realize this. It's the effect of the macrocirculatory interventions on the microcirculation. That's what I want you to understand. That's what we're measuring with CRT. In addition to microvascular abnormalities, but if you look at the ANDROMEDA-SHOCK-2 interventions, they're all macrocirculatory for the most part. We could talk about, whether or not some of them are microcirculatory resuscitation techniques. So, but essentially, most of what we're doing in ANDROMEDA-SHOCK-2 is we're personalizing macro hemodynamic, meaning the large vessels, to improve the microcirculatory flow and use the microcirculatory flow measure to see if we're doing a good job and to really individualize it to the patient. Think about that. That's game changing, because surviving sepsis, all of the sepsis resuscitation we were doing, it's based on very macro hemodynamic monitoring. MAP of 65. Okay, the heart's pumping better with inotropes, etc. But what we really want is we want to improve the patient's tissue perfusion, and the microcirculation is a better monitor of that. So when you squeeze the finger and then it refills in less than 3 seconds, what you're essentially seeing is that hemoglobin is able to pass through rapidly enough to the venules and capillary beds to tell you that A, there can be the passage of that blood, and B, it's happening quickly enough that whatever's happening macrohemodynamically is pretty good. That's essentially what we're saying. We're saying, okay, the flow at the tissue bed, and remember, we're measuring a distal tissue bed at the level, of the fingertip. That is not heart, lung, brain, which is going to be preserved even at the very last vestiges of life. So if you're perfusing your distal fingertip pretty well, then we can make that in our minds as a surrogate. You're perfusing the rest of your body pretty well. The gut, which is, a real thing that gets killed off very quickly, just like the skin. So we can feel pretty good that our resuscitation is great. When you have the macrohemodynamic variables going well, but the microcirculation is crap, then you get things like gut translocation of bacteria and all of this, cycle of dying in sepsis or dying in exsanguination. It's the same thing. So that's why CRT is such an important thing. So now what did they do to optimize CRT? Well, actually, before I go there, there's some other microcirculatory markers we should be looking at as well, in addition to just CRT. This was a primarily CRT focused one, but I think broadening that to other microcirculatory markers is worthwhile for our own clinical practice. So modeling is always put up there, and it's worth looking at. You should look at it at the legs. It usually starts at the knee, and depending on how much modeling there is, you can say, ooh, this is a marker of bad perfusion to the microcirculation. So look for that, and hopefully you all are. It's an easy win to say, oh my God, the entire middle of their legs are modeled. This patient's in dire straits, right? And their CRT in that case should be significantly abnormal. Perfusion index. We all have pulse oximeters, right? Every hospital, every bed has a pulse oximeter for sick patients. Do you guys have on your monitors perfusion index? Like, is that universal? No. Now, when you say no, you got to really be sure, because Sometimes it's there, but you have to actually put it up. Like you have to go into the monitor settings and actually, some people are saying yes. You actually have to go in and just, either it's there and you're just not looking at it because it's in tiny little letters, or it's there and you have to turn it on. But a lot of them have, because it's a freebie, right? Like you're not adding anything to the monitor. They should all be able to do it. So check. This is like a checklist task to go home to your next time you're in your hospital and say, do I have perfusion index? Because perfusion index is a real-time monitor, or something very similar to CRT. And just from the pulse ox, depending on the degree of the adequacy of the waveform being monitored, you could say perfusion index is good or crap. And the cutoff, we say 1.4 to 2 is a gray zone. Less than 1.4 is indicative of basically the same things as a extended CRT time. Greater than 2, you can feel pretty good about their perfusion. And again, that 1.4 to 2 range for perfusion index is a gray zone. We don't really know. But like if you see something like it's 0.4, then yeah, that you don't even have to bother with the 10-second cap refill time. They probably have what's going to be an extended cap refill time. All right, so we have these markers of micro circulatory flow. Let's see what macro hemodynamic interventions we could actually do. So the first thing they asked in the study, is the pulse pressure less than 40, right? So you have an abnormal CRT, is the pulse pressure less than or greater than 40? It's a question you don't have to ask. And I talked about this with the study authors, because mathematically, if your MAP is greater than 65 and your diastolic is less than 50, which is the piece of the intervention they're going to do if the pulse pressure is greater than 40 in the flow chart, which I would put up if my computer ever will reboot, then you are going to check the diastolic blood pressure. You don't need to look at that pulse pressure. It's not mathematically possible to have a diastolic less than 50, a MAP greater than 65 without a pulse pressure that is greater than 40. So you don't have to even think about pulse pressure. They should just take that out of the algorithm. So the first step you should do if you're following ANDROMEDA-SHOCK-2 is look at the diastolic blood pressure. And if it's less than 50, they advocate increasing your vasopressor dose to get the diastolic blood pressure greater than 50. And what's that going to do? Well, it might have some heart effects because we know coronary filling is during the diastolic phase of blood pressure. But what they're doing it for is its microcirculatory effects primarily. Like maybe raising that pressure is going to have benefits to the microcirculation and then the heart as well. So what do you folks feel about that? Are you doing it? Do you buy it? What's your feelings?
We were probably quite likely optimizing our vasopressors to our MAP rather than the diastolic, but this is definitely something that we should probably be adopting.
Yeah. Apoorva, do you have anything to weigh in?
No, I mean, never really thought about that being the kind of target. So like Rahul was saying, we were always focused on the MAP rather than this.
Yeah, and remember that in order to even get into this personalized hemodynamic, they've already optimized MAP. So that's off the table. That macro hemodynamic thing, we've already done it. But what we're thinking through and what I want you to have in your mind throughout this is, but the patient has an abnormal CRT, right? Like that's what you got to keep saying to yourself is for each thing we're doing, it's not that we're doing it empirically. That would be back to non-personalized treatment. It's like this patient's showing us microvascular failure. Before we start attributing that microvascular failure, microcirculatory failure to the microcirculation itself, right? Before we start saying, oh, it's shunting, it's blockage, it's all this crap, because we don't have much ability to fix that. Before we do that, we're going to say, okay, is there still macro hemodynamic interventions we could do? And one of them is maybe the diastolic's too low, because imagine that patient who has really good heart function, right? Like that 28-year-old with MRSA, pneumonia, sepsis, right? Like their catechol system intrinsically is good, but what really is good, they have nice, strong, young hearts, right? So they might have a sky-high systolic blood pressure and a very low diastolic. And their MAP looks okay, right? They have a MAP of 67, but their diastolic's in the toilet. That patient is the exact one they're talking about here. And now if their CRT was normal, we'd say, okay, let's let it ride. But their CRT is abnormal. So now they're going to push the diastolic blood pressure. Well, I'll tell you personally, I like this. I think this is worthwhile. Again, if the CRT is abnormal, because we don't want to have excess vasopressor doses with a normal CRT. But if the CRT is abnormal, all right, let's see what happens when we push the diastolic to 50. There's some additional work showing just that patients benefit and have a association with decreased mortality if we have a relatively good diastolic blood pressure. So I think this one, even though we don't have great evidence for it, is worthwhile. And I've actually adopted this into my practice. Do we have any dissenters? Anyone who thinks this is too soon, we shouldn't do it? Any thoughts? And again, this is not going to be fun unless people are willing to talk. So how do we get them to talk, Apoorva? What do we do? Should we pay them? Should we give them gift certificates? Do we start docking their pay? What do we do to get people to speak here?
How about a coupon code for kind of 50% off on EMCrit subscription?
Well played, my friend. All right, we'll see what we can do on that, but please, folks, you got to weigh in.
No,
Anyone
I
have any
think
comments? Rahul, you're not allowed to talk anymore. You're gonna be stealing the overt pressure for people to speak. You're gonna eliminate the uncomfortableness of me just sitting here and not saying a word. So you've been so good. Let's see if anyone else is willing to be brave. All right. Well, if no one speaks, then I'm just going to say all of you are going to do this tomorrow in your practice. All right. So that's the word. So unless you're willing to weigh in, then you should just start optimizing the diastolic blood pressure to greater than 50 if the patient's CRT is abnormal. All right. Well, then you're all doing.
Physiologically, it makes absolute sense. But my only question in my mind is, are there any studies specifically looking at this, which I'm not aware?
And there are, but they're all associative. So, they're not the studies you want, which is let's have a direct result that gives us the ability to say causation. And we don't have that, right? Because obviously patients who die are probably going to, at some point in their care, going to be having intractably low diastolic blood pressures. Yeah, so it's hard to say. Okay, so now the next thing they ask you, either diastolic was already greater than 50 or it is after your intervention, is the patient fluid responsive? Now, remember, these patients got initial resuscitation already. They had their macrocirculatory resuscitation. And in this trial, it was about 20 mLs per kg, which for me is very reasonable. 20 mLs per kg is, I think, what we should be doing empirically. Now, the argument for empiric, and empiric doesn't mean in every single patient. If they have different physiology, then obviously you'll moderate that. But as a general rule, I think 20 is very reasonable. And ostensibly what you're doing with that initial volume resuscitation at the beginning of resuscitation is making up for all the insensible losses of their illness. Generally, if they're febrile, they've been sweating, they probably haven't been mobilizing to drink as much as they do normally. So that's what you're really doing there with that initial volume resuscitation. And you can make the argument that surviving sepsis campaign has kind of gone off the rails with this 30 mLs per kg because there's no evidence for it. And it came out of nowhere. Surviving Sepsis Forever was going with the 20 that was in the big sepsis trials, early goal-directed therapy, and then the 3 international trials. And then somehow 30 came. And I don't understand why. I've talked to all of the people involved in surviving sepsis. It makes no sense. They have no evidence. They just stick with it. I think it's silly. 20 is a good number. If the patient has other things going on, maybe less, but 20 I think is very reasonable. It's what I tell my residents is unless something weird's going on, just give 20. What are you folks doing? What's your initial volume resuscitation?
I think probably we go with the same as well. Probably the maximum is 20. I think sometimes even we kind of go with even smaller boluses than that, but I think probably the maximum is 20.
All right. And we have a lot of evidence saying that, the harm from 20 is probably not there. Even in the patients we don't want to give fluids to, like the renal failures and the heart failure patients, 20, you probably get away with it. And Nate Shapiro's work would tell us that you could get away with smaller volumes after that initial resuscitation. But even in his trial of fluid restriction in severe sepsis, that they had already gotten between 20 and 25 mLs per kg. So like we've not done the real trial that would give us smaller volumes as the answer. Every trial out there, the patient's got at least 20. So we don't have a baseline to go lower. Like I'm all for, you really have to prove to me they need the fluid after that. But before that, I think it's a reasonable amount of fluid. Okay, so most of the patients got 20, and now they're going to ask themselves, are the patients fluid responsive with some objective marker of that, whether that be ultrasound based, whether that be cardiac output monitoring. Now, at the bedside, it's really a pain in the ass to do these fluid responsiveness tests. I don't know about you, but I haven't found one that's not a pain in the ass. In the ICU, where I have cardiac output monitors, it's not a pain in the ass at all. It's fine. But at the bedside, it's kind of irksome to have to do this. So, what markers of fluid responsiveness are you folks doing in your practice, if any? Because it's fine for you to say none, because, like I said, I don't find them very enjoyable to do in the emergency department. So, who is willing to tell us their practice for determining fluid responsiveness?
We tend to use IVC quite often because it's easy and it's something that's easy to train most of our residents to. But one other thing we were also looking at, especially since we get a lot of cardiac and renal patients, how good is it to use echo and passive leg raise to check for fluid responsiveness, and then based on that give them eloquence of say 250 ml or 500 ml progressively? What do you suggest using that as a surrogate marker?
Okay, so there's two things in there worth talking about. So the first one is IVC, and Raul, how are you using the IVC? Are you saying in a non-intubated patient you're using IVC, or just intubated ones?
No, non-intubated too.
Yeah, so IVC doesn't work. Now, that being said, I use it as well, but I'll tell you how I use it. It's probably how you use it too. So, I think you're on a very good clinical space, but I think we should just be really clear about this. So IVC works in intubated patients who aren't taking frequent spontaneous breaths, or you could really get a moment in time where they're not taking a spontaneous breath. And then its expansion of the IVC is actually a marker. And that's pretty good. For non-intubated patients spontaneously breathing, IVC doesn't really answer our question for fluid responsiveness. What it does is it really starts indicating fluid tolerance. And a small IVC, a collapsing IVC, we used to think, oh, that they're fluid responsive. No. What it really tells us is they could take fluid safely. And I think that's still an incredibly valuable marker. And I think your practice is the practice that I would advocate as well. And we'll get there in a second. Let's stick with the fluid responsiveness markers. So you had asked about using passive leg raise with echo. That is very well proven. If you get a cardiac output, or more accurately, a stroke volume using LVO VTI, right? That is an accurate representation of stroke volume. And if you do a passive leg raise, which allows a translocation of fluid temporarily, and the stroke volume goes up, then the patient is fluid responsive. That's definitive. That being said, huge pain in the ass. Huge pain in the ass. First of all, passive leg raise is a pain in the butt, right? It's fun to demonstrate to a medical student. I'll do that once. I'll show them on a cardiac output monitor. Hey, look, their stroke volume goes up when, or their cardiac output goes up when we do a passive leg raise, and that 250 to 500 cc's of fluid went up, and that shows us the patient's volume responsive. And then I'll never do it again because it's such an annoying thing to have to do. The patients hate it. You're messing up all the nurses' lines and stuff. Like, it's not fun. And so you do it once. Let's say you had the wherewithal to measure a LVO VTI, which is also, it's pretty involved. It's not like a 2-second thing. It's not like, is there fluid in the Morrison's pouch, right? Like Morrison's pouch, pop on the probe. Yep, there is or there isn't, right? Like, this is a whole thing. You got to find the spots. You got to, do the Doppler measurements. It's like, you could get good at it. It can become fast. So you do one, then you do your passive leg raise. Then you got to do another one to see if there was an effect. I don't know. I think it's not really ED ready. And the ultrasound guys will try to convince me that it's a good thing. And I'm like, no, it just doesn't pass the sniff test for I want to do this constantly at the bedside. So yeah, it doesn't do it for me. Doesn't do it for me. So what else? Is anyone doing any other markers of fluid responsiveness?
Somebody said lactate in the comments box.
Well, I don't know what to do with that. So, okay, let's delve into, because thank you for being brave enough to say that, because it gives us the opportunity to do a jumping off point for a few things. First of all, elevated lactate does not in any way indicate the necessity of volume. And we shouldn't be resuscitating elevated lactates with fluid. And that was like one of the most pernicious things that came out of the early sepsis work, was the conflation of lactic acidosis with the necessity for volume. And what elevated lactate in sepsis almost always represents is inflammatory response. It's our own endogenous epinephrine and other neurohormonal chemicals are conspiring to change the way we metabolize glucose in the presence of adequate oxygen. So, what initially people were thinking is, oh, they're switching over to an anaerobic state because there's not enough hemoglobin coming by carrying oxygen, and therefore, if we give more fluids, we'll increase preload, and therefore cardiac output, and therefore we'll have lactate clearance. A, it's not the cause, and B, it's not the result of that. So stop treating, and I'm not saying anyone's doing this, even the person who suggested in the comments. I'm just saying, like, teach your residents, lactate elevation never gets treated with fluid. It doesn't mean they don't need fluid. They might, but the lactate is not the indication for that. So don't. And when you look at this trial, what they did so beautifully is CRT abnormal may indicate the necessity of fluid, but they make you prove it with a test of fluid responsiveness. That's the magic of this protocol. And so you're not allowed to give fluid in this protocol at any point unless you prove that it's going to have a beneficial effect. But the beneficial effect you're proving by doing all of the markers of fluid responsiveness don't account for the fact that effect from fluid that's predicted by fluid responsiveness is transitory, right? So patient has markers of fluid responsiveness. Their cardiac output, their stroke volume increases with either passive leg raise or a volume challenge or a cardiac output monitor. That doesn't mean that's going to still be there 45 minutes later. We know that the fluid leaves the bloodstream and gets extravasated in sepsis. We know we have leaky capillary beds, that we have interstitial volume accumulation. And we know it's really bad until we have the inflammatory response of sepsis fixed. So just because the patient's volume responsive doesn't mean that was beneficial long term, and it might actually be harmful. So I applaud the ANDROMEDA-SHOCK-2 people for forcing a volume responsiveness check. But that being said, I still don't know if you need to give volume. So here's how I play it. Because the first part of their protocol that we're still in tier 1. They have tier 1 and tier 2 in the study. In tier 1, you check volume responsiveness. If they are volume responsive, you get 500 cc's of fluid, right? Then you see, is the CRT normalized? If it's not, you check fluid responsiveness again. They're still fluid responsive. You could give 500 cc's more, all right? So max 1,000, which takes you from that 20 mLs per kg to approximately 30 mLs per kg. Here's how I play it. It's very similar, I think, to what Raul was advocating. I tell you, do this instead. Okay, their CRT is abnormal. That's bad. Let's see. Let's look at their IVC. Is their IVC plethoric, right? Oh, it is. And we're talking about a non-intubated patient. Okay, we're not going to give fluid. But what if their IVC is collapsing? It's small. Okay, that doesn't tell me they're volume responsive, but it does tell me they could tolerate additional fluid, right? That's volume tolerance, which is a different thing. And while you could say like a volume tolerant patient may be fluid responsive and a fluid responsive patient is probably volume tolerant, the two are really in some ways orthogonal, meaning you need to check both. So we're going to check one of them. We're going to check volume tolerance, and we're going to say, okay, the volume tolerant, I'll give 500 cc's empirically, not checking fluid responsiveness. Okay, what does CRT do? CRT still abnormal? Okay, let's check the IVC again. Okay, still collapsing, still small. Let's give another 500 cc's. And that's it. That's all you get in tier 1. Now, what does this allow you to do? It allows you to obviate the necessity for all that complicated echo stuff to do volume responsiveness. And at the worst, even if they didn't need the fluid, even if they weren't volume responsive, you've taken them to where surviving sepsis is recommending you start at. They're recommending the same 30 mLs. Okay, well, we took them there. We were smarter than surviving sepsis. We actually looked for volume tolerance, and we now have finished tier 1 of ANDROMEDA-SHOCK-2 without having to do all the cardiac output monitoring stuff. I feel pretty good about that, right? So it means for me, I'm never going to give 30 mLs per kg empirically. I'll give 20, and then I'll check my work if only if the CRT is abnormal. If the CRT was normal, then they only get 20 mLs per kg. They never get the 30. Feel pretty good about that too. So that's how I handle tier 1. All right, so let's stop there. Any questions before we go up to tier 2? You got to have questions, guys. Come on. We're not asking you to answer questions. We're asking you to have questions, right? Like, so this is much lower stress here. We're not putting you on the spot. But is everyone just completely agreeing with everything I've said so far? Like that's not good. You shouldn't do that. Like the whole point of critical thinking is to question. You should have thoughts about this. You should say, Scott, I don't buy it. You should be doing volume responsiveness on every single patient. Anyone have any questions? All right. Well, we'll keep going then. So now we are into tier 2. Now you got to understand, in ANDROMEDA-SHOCK-2, the reason they broke it into these tiers is because these were low income settings for the most part. These are not places that have immediate access to ultrasound necessarily. All right. Ultrasound is something like, okay, well, I guess this is now a tier 2 patient. We tried to optimize tier 1. Now let's seek out an ultrasound. Now maybe we seek out more advanced monitors. Now maybe we seek out more difficult from a resource perspective things to get. Right now we're going to say, oh, this patient's really sick. Because the thing is, so many, I forget the exact percentage, but so many patients normalize their CRT just with those 2 tier 1 interventions. So think about that. Just increasing the diastolic blood pressure and giving an extra 500 to 1,000 cc's of fluid was enough to take the majority of the patients from abnormal to normal CRT, which means, like, without an echo machine, you can fix most of these patients from a personalized hemodynamic standpoint. That's great. From the ED, even if you have ready access to ultrasound, it means you don't necessarily have to do that to fix most of your patients, which is fast, right? That's what we need in the ED is we need fast but effective. So that's super interesting. Okay, so now in tier 2, you got to do an echo, right? Now, I would have done an echo on a patient on vasopressors in septic shock before this point, right? So they're giving the ability to avoid having to do it in their protocol for the low resource issue. I probably would have done it beforehand, which might change the way I approach the resuscitation of these patients. But now for the first time, they're going to do an echo. And if the echo looks bad for either the left heart or the right heart, they're going to optimize that to improve the patient's abnormal CRT. So, and this they left up to the clinicians. So it's going to be up to you to what to do for that. If the right heart's bagging out, then maybe it's inotropes, maybe it's reducing unnecessary PEEP, right? Like that's what you're going to do for right heart failure. For left heart failure, probably inotropy. You're going to ask yourself, is the afterload too high? All of the stuff we do normally. And we're going to optimize that, and then we're going to recheck the CRT. And if it's normalized, great. We knew our problem was a cardiac output problem from intrinsic cardiac issues. And if not, then we'll talk about what to do in a second. But think about this. If you had done the echo earlier, then it's interesting. Would we have changed what we did? Let's think about that, right? So you do an echo, and let's say you see a crappy left heart function. And, if you have history, you could say, oh, maybe that's pre-existing cardiac dysfunction from the patient's baseline. Or maybe it's sepsis-induced cardiomyopathy, right? So would you still optimize the diastolic? I would say yes. Even if you had an echo showing poor cardiac function, I would like to see what that heart does with a good diastolic blood pressure. So I would still optimize the diastolic blood pressure greater than 50. Would you still give the fluid? You saw a crappy, maybe underfilled LV. I probably wouldn't. I would say this patient doesn't need additional fluid. What they need is some inotropy, right? And so I would probably put that patient on low dose epinephrine, or maybe you like dobutamine, and see what happens then before I gave the fluid if I'd done the echo earlier. All right. But even with that additional 500,000 cc's of fluid, if you didn't do that, it's probably okay. It's not an enormous amount of volume for an initial resuscitation. All right, but now we're looking at the heart, and we're going to optimize the heart. And the heart's optimized, then we're going to again check capillary refill time. If cap refill time is still bad, then the next step is more fluid responsiveness checks. And you're going to give 500 cc's at a time until the patient's no longer fluid responsive. Now the problem I have with this, and I talked to this with Glenn and the other ANDROMEDA-SHOCK-2 authors, is there's no checks of fluid tolerance. And you can have patients that are fluid responsive who can't tolerate that fluid. And so I think we should be doing both if you're really going to give more fluid after that additional 30 mLs per kg. And that involves, continuously checking the IVC. And if the IVC starts getting big, then you have to start checking things in the VEXIS world. Does everyone know what VEXIS is? Does anyone not know what VEXIS is? All right, VEXIS is ultrasonographic markers of venous excess pressure. And so if the IVC is small, then generally you get a pass on the checking the additional stuff. But if it's large, now you have to start asking yourself, okay, well, what's going on with things like the portal vein, the hepatic vein, the renal vasculature, and ask, is there still easy flow through the veins, or is there venous congestion? And that venous congestion can cause organ congestion, and then you get organ failure as a result of excess pressure on the venous side. And even if they're fluid responsive, I would stop. Now, they do talk about this in terms of the easy macro markers, like the patients start getting increased CVP if you're measuring it. Most places aren't, or actual lung edema, stuff like that. But they're not looking at the, I think, earlier warning signs that you could get from the VEXIS score. I'm very weary of giving additional fluid beyond 30 mLs per kg unless there's a real, for me, it's beyond even the proof of these markers. I wanted to understand where it came from, right? Like, no, so if you have a patient who's septic and vomiting, all right, I'm all for it. Let's give more than 30 mLs per kg. They probably have real fluid losses. But if not, I got to ask myself, where did this volume go? Right now, look, if the patient's been like 2 weeks with this illness and just refused to come to the hospital, okay, again, maybe I'd buy it. But if they've only been sick a couple of days, I don't know where this fluid really went. Then even then, I got to ask myself, do they really, really need additional fluid? But the protocol would have you give an additional fluid, 500 cc's at a time. Each time you give 500 cc's, you have to recheck the CRT and you have to recheck volume responsiveness. And I would say also recheck volume tolerance. And that's the only way you get additional fluid in. And each time they'll see, did the CRT normalize? And if it didn't, they'll keep going. All right, let's say you get to the point where the patient is no longer fluid responsive, or they are now not tolerant of additional fluid. Then the next step is you ask, does the patient have baseline hypertension? And if they do, then you're going to push their mean arterial pressure goal from 65 to 85. All right. Now, subsequent to the ANDROMEDA-SHOCK-2 trial being completed, we had a new randomized controlled trial come out, sepsis spam, right? Was that it? I wish I had my computer up. That actually showed harm from pushing the MAP of 85. And when I asked the ANDROMEDA-SHOCK-2 authors about this, their take was that they're doing it for a short period of time in patients who have proven microcirculatory failure. So it's kind of different. I don't know. I don't know about this one. And so let's bring that up to the audience. Now, with the results of, it was Optipress. Sepsis spam was the, my computer's finally up now. Sepsis spam was the positive trial that, preceded ANDROMEDA-SHOCK-2. And then Optipress was the trial out of Japan that actually showed harm. It was actually stopped early because of it. So now with Optipress, are you agreeing with the ANDROMEDA-SHOCK-2 people that we could still be doing this MAP push to 85, or are you leery of it? Are you scared of it? Who's willing to weigh in? All right. Well, I'll tell you. Was someone going to say something?
Not too sure, to be honest. I don't think we have a strong opinion either ways, in all honesty.
Yeah, I think that's the right evidence-based stance to be in. Like, we just don't know. I like, if I had nothing else to offer these patients and their CRT is still 8, I'll try it, because that's associated with death pretty strongly. Like, yes, or strongly abnormal CRT is really bad. So I'll try anything at that point. And I think the harm's not going to be there if you're doing it for the period of time where the patient's still in massive inflammatory response. If it's going to happen for like 12 hours, 24 hours, versus what happened in OpPress is they actually changed the overall goal of the patient for their clinical course to 85. That might be more problematic than just trying a brief period of microvascular resuscitation at that 85. But I'd like to see more evidence on this one. Okay, so if the CRT normalized, you're done. If it didn't, then you go on to the last piece of ANDROMEDA-SHOCK-2, the dobutamine test. And what they're going to do now is, even if the patient wasn't on inotropes beforehand from their echo function, then they're going to put them on dobutamine, fixed dose, 5 micrograms per kilogram per minute. And the idea of this is, yeah, maybe there'll be a heart response, but what you're really trying to do is microcirculatory resuscitation. And we have some, trials, some animal-based, some human-based, that say dobutamine might be a microvascular resuscitation. Now, the actual good trials were negative for this, right? Like, the Bakker's work indicated this may have a benefit, but when they actually looked at it, like, it's very iffy whether there's great evidence for this. But again, those trials weren't done personalized. They weren't looking specifically at a population who had abnormal CRT indicating microvascular failure. Though I believe there were some trials looking at near infrared spectrum, spectroscopy, and stuff like that did, was a marker of this. But there is indication in the literature of microvascular resuscitation with dobutamine. So this is like their last ditch effort to improve the CRT. So they're going to just put them on a fixed dose of inotropes, dobutamine specifically. And then if their CRT normalizes, great, you win. If it doesn't, then they go to rescue therapies. Rescue therapies are left up to the individual clinicians. They didn't specify that. So that's the ANDROMEDA-SHOCK-2 protocol. We've talked about which ones I think are applicable to the bedside, how to make it easy to do. Let's stop there for questions about all this.
I think one of the questions was going a bit back when you were discussing the tier 1. So somebody asked, what's the value of monitoring blood pressure at that stage? So would you base the decision only on the blood pressure at that point?
No, I think that's a great question. So the macro hemodynamic markers, like, as soon as they fall off on those obvious ones, like their MAP drops to 50, then you just go back to the empiric resuscitation, and you bring their MAP back up to 65. So that's just built in. So, if at any point their MAP drops, you're going to fix that. You're going to increase your vasopressor dosage. You're going to add on additional vasopressors. All of that is just built in. So that yep. So they leave personalized, and they go to, empiric. And so that, that's just standard resuscitation. So, if their MAP drops, fix it. Now, what's interesting, though, is that we oftentimes resuscitate MAP with fluids. And that's what ANDROMEDA-SHOCK-2 says you shouldn't be doing. And I think they're so right on that, because again, for most patients, they don't have enormous volume losses. What they have is their venous side becomes unstressed volume, which means that even though the fluid's still there, it can't get back to the heart. You need to squeeze back. So just like the arterial side vasodilates in sepsis, the venous side vasodilates. And as a result, all the fluid they have and all the fluid you've given them that 20 or 25 or 30 mLs per kg, can't get back to the heart without vasopressors, which is why I advocate, even if the patient doesn't have the necessity overtly, their MAPs are okay. Like, let's say you have a patient with a MAP of 68, but you're like, oh, I think we need to give them more fluid. They're volume responsive. I would prefer that patient went on some vasopressors rather than got more fluid, because volume responsiveness still tells you just that they need more fluid back to the heart. It doesn't tell you why. And the better thing to do may be to squeeze down the venous side without giving more fluids, because more fluids actually will get back to the heart. And if that point's not understood, then tell me, because it's so important. It's such a key point. And so I would say a patient who got 20 mLs per kg but is not on vasopressors probably should get put on very low dose norepinephrine if they are still showing volume responsiveness before you gave more fluid. This is a very heretical stance. But what you'll find is if you put a patient on 2 or 3 of norepi, their MAP doesn't increase. We have studies proving this. You're not sending them up to deleterious MAP levels. What you're doing is the first response to norepinephrine is venous constriction, not arterial constriction at the low doses. So as a result, what you're going to do is you're going to have more volume that you've already given actually getting to the heart versus giving more volume to fill. Essentially what happens is your pipes on the venous side go from normal size to like the size of a swimming pool. And you could keep trying to fill up that swimming pool by giving more and more volume, or you could just shrink the swimming pool back to a normal size without having to give any additional volume, but you're still getting what you want, which is preload. You're still getting volume back to the heart without having to give additional fluids. So let's see how that sits. Does anyone have any disagreement with that?
No, I like how you bring that up. So, and in fact, that's the reason why I was also hoping to ask you a question on how quickly should we consider noradrenaline while you're considering fluid simultaneously, especially if you know that the patient is quite unwell, extremely hypertensive, and you're suspecting that the patient is fluid responsive. As you said, start helping with the venous circulation itself, decrease the size of the pool even before you give the fluids. So how do you want us to go about that? What would be the correct litmus
thank
test
you.
of saying this patient needs NORAD now?
Such a good question. So my take, and again, like this is my take, this is not necessarily what the guidelines will tell you, but I think the evidence is better on my side, is if the patient actually has a MAP of less than 65, then you don't wait to see what happens with your volume. That patient immediately gets norepinephrine on to bring their MAP up to 65. And you empirically give 20 mLs per kg. So now you're doing a really balanced resuscitation. You're giving fluid and you're squeezing down the venous side to actually get that fluid back to the heart. So I never, ever will give fluid for a MAP of 58 and see if they get up to 65. I want the vasopressors on. I want the vasopressors on for the venous side. I also want the vasopressors on because I want to force the issue of putting this patient in an ICU. I want this patient in an intensive care unit. And what I see all the time in hospitals is these patients have borderline MAPs. The ICU fellow comes down and they say, give more fluid, give more fluid, give more fluid. And the team does it. And eventually the MAP gets up to 68. And then the ICU fellow says they're safe for the floor. And then those patients die. What I want is I want that patient in an ICU. That patient, if they're severely septic, deserves to be in an ICU. The way patients die in septic shock is not the majority of them. They don't die from this progressive multi-organ failure that eventually they, keep getting worse. The way these patients die in the hospital is sudden cardiac arrest. That's the way they die because they get put in an unmonitored setting. And then, their MAPs do that roller coaster thing where, they're 67, 58, 65, 52. Eventually, the lower dip of the roller coaster gets below 40 and their heart stops and they die. And then since they're on a floor, no one realizes it for a half hour. That's how patients die of septic shock, the majority of them. So I want these patients in an ICU. So I want them on vasopressors as soon as possible to force the issue that you can't put these patients on the floor.
There's another question.
Okay, other questions?
Yeah, there's another question. What's the only one best thing we should do for checking fluid responsiveness in the ED?
Okay. So the technology coming down the pike is stickers that go over your carotid artery. And when those come, you'll finally have, if they're affordable, we'll finally have a way to accurately check the fluid responsiveness in the ED because we won't have to do all the complicated echo stuff. You could either just give a volume challenge and see what happens to your cardiac output based on Doppler carotid measurements that you don't have to do. The machine's doing it. It's a sticker, it's easy. So when that comes, I think that'll be very ED friendly. And like John Emil Kenny, who is one of the people on the VEXA study, he's the one working on this with the company creating it. And if it could be relatively inexpensive, I think that will be a real win. I think until that becomes inexpensive and available, I want to see more studies on looking at the carotid artery, because it's so easy to get. All of us could just slap a probe on the neck, instantly be able to tell. And with AI being integrated into the ultrasound machines, we won't have to do all the Doppler measurements. Hopefully, we could just put something on the carotid and it will tell us a cardiac output or a stroke volume. There's no reason that can't happen in the next 6 months. Like the technology is all ready for it. Just someone has to build something easy to do. But that's what I want in the ED. Until then, again, I don't check volume responsiveness very often in the ED. I know how to do a VTI. I don't do it because it's such a pain in the butt. So what is the one best thing we should do? Is stop doing fluid responsiveness check. Here's the paradigm that allows you to stop doing it. Just don't give more empiric fluid for a patient that doesn't have obvious loss of volume. So give 20, do what I said, check fluid tolerance with the IVC. If they're fluid tolerant and their CRT still abnormal, give 500, check the IVC again. If they still look fluid tolerant, give another 500, and then stop. Just stop. Don't give fluid. Just don't give fluid anymore. And then you don't have to check more volume responsiveness. They get so much fluid in the care of a septic patient from all of their vasopressors, their antibiotics. They get so much fluid. And we don't volume reduce like they do in the ICU. In the ICU, they do concentrated infusions. We don't do that. So they're getting a ton of fluid. So just don't do it. And then you don't have to have a best way for checking volume responsiveness because you don't need it. Don't check volume responsiveness is what I would tell you. Or do, but just understand, like, it's a pain in the butt. And there's a lot of sick patients in the ED that need care. So we're not a one patient optimization strategy like it is in the ICU. We have to optimize for the whole department. So if you have someone on an ultrasound rotation in the ED, by all means, let them do the whole thing, get a VTI, which is the best. It's the best way in the ED to get an accurate volume responsive measure. Get a VTI, do the passive leg raise, get another VTI. Let them do that. But if you don't, if there's multiple sick patients to see, then just don't do it. Just stop giving fluid and then you don't have to worry about it.
I think I have another question. Just going back to the study, it makes absolute sense to do the personalized resuscitation than going like a generic resuscitation formula. But if we kind of notice at the endpoint, so I think one of the endpoints was mortality. The other one, if I remember correctly, was if they were weaned off the life support or on from the inotropes, how quickly they were weaned off. And the third one probably was the hospital length of stay. So I think one area where there was significant difference was weaning off from inotropes or life supports, where it showed significant difference compared to kind of the standard group. Whereas there was no significant difference in mortality or the hospital length of stay. Now, since the study is not blinded, there is always a subjective element of when people kind of stop noradrenaline or when they stop inotropes. So does that kind of bring in a bit of bias, and does that make you think a bit differently about the study? What's your take on that?
It doesn't make me think differently at all because, like I said, I look at this as pretty much a negative trial. So it doesn't make me look differently because your points are absolutely correct. But that's also the reason I think it was a negative trial. Is the problem is this group who had done ANDROMEDA-SHOCK-2 had already been a part of ANDROMEDA-SHOCK-1 for the most part, and they all believed it. And so what I really think the bias is from the lack of blinding, and I don't think blinding would have even helped this, is I think even in the standard care group, they were still doing most of this stuff. That's the problem, is what we call, bleed in or bleed over, is that the treatment group bled into the control group to a huge extent. These people were all believers in CRT. They all were optimizing their resuscitation based on it. And as a result, I don't think there was a separation between groups because they were probably doing pretty much the same care in both groups. So that's why I still am telling you, I take a lot of the lessons from this trial and want to use them at the bedside, even though I don't think this is truly a positive trial. because I think the reason it wasn't positive is both groups were doing the same thing. Okay, so some of the other questions from the chat I just really want to hit real quick is one person said that they don't use CRT because a lot of their patients have cold periphery by the time they get to the ED. That would be weird in septic patients because they are profoundly vasodilated for the most part. So even in their by the time they get to the ED, they really should have warm extremities. If they don't have warm extremities, that you could still check a CRT, but you don't even need to, kind of, because what they're telling you is if it's septic and their extremities are cold, their CRT is going to be abnormal. That's still an enormous marker. That's an immediate marker of the need for cardiac output. Like something very bad has happened if your septic patient has gotten cold extremities. They need immediate heart resuscitation. And so I would either throw an echo on and prove it to myself, or you don't even need to. That patient needs volume inotropy to improve their cardiac output immediately. Cold extremities don't invalidate the CRT. It's just that it's so far past the point of safety. Like the patients they were doing CRT on are still in the vasodilated portion of their resuscitation. If you get a patient who is so far gone by the time they get to the ED that their extremities are cold in sepsis, that patient needs immediate cardiac output resuscitation. Okay, let's see some of the others here. Okay, let's see. No, that one we already answered. Okay. Pleth variability in spontaneously breathing patients. Yes, it works in spontaneously breathing patients. And does the operator-dependent nature of cap refill time limit the generalizability of ANDROMEDA-SHOCK-2? No, you should just do the right CRT. Like I said, you don't need a glass slide, so that's easy. That's completely unnecessary, and the ANDROMEDA-SHOCK-2 authors agreed with that. You do need a stopwatch, which everyone should have. Everyone has a phone. If you don't have a phone, then buy an actual stopwatch. Or if you don't, then they still, and in their South American countries, they're still using 1 Mississippi, 2 Mississippi, even though I would think there would be a word in Spanish you could use instead of Mississippi. But honestly, like, does anyone not have a smartphone? I think we all have smartphones, right? Like someone in the department who's next to you is going to have a smartphone. Just monitor it with a stopwatch, and then it's completely not operator dependent anymore, right? Like just you squeeze the finger as hard as you can, which is what the glass slide allows you to do, is not squeeze as hard, but I'm just going to, I don't have the glass slide. I'm just going to squeeze as hard as I can and then use a stopwatch. And then the operator dependent nature disappears. So I don't think it should limit the generalizability. It just really requires people to do it the right way. All right. How reliable is non-invasive in shock patients with a diastolic less than 50? Probably pretty reliable, but not perfect. We have the arterial line study that was looking at MAP. Their next thing is to look at diastolic and systolic to see how accurate it is. I think it's probably okay. My belief is in a profoundly vasodilated patient, the blood pressure cuff is probably pretty good. It's probably pretty good. As opposed to profoundly vasoconstricted patients where I think I worry about the accuracy of systolic and diastolic. But it's a great question. I don't know is the answer, Rakesh. But I feel pretty good about it to push the diastolic on non-invasive. That being said, I love arterial lines in my septic shock patients, and we will place radial arterial lines almost always just because it makes things so much easier from the monitoring perspective. And it gives us once they're intubated, a very easy cardiac output monitor in the ED for things like volume responsiveness, because you can now use changes in your pulse pressure, changes in your MAP to guide it from a specificity point. So if you do a passive leg raise in an intubated patient or even a non-intubated patient with an ART line, you do a passive leg raise and their MAP goes up, they definitively are volume responsive. If it doesn't go up, then the sensitivity is not there, but it now becomes an easy marker in the ED for, yes, this patient is volume responsive. But again, I don't care as much about volume responsiveness as other people do, so that's not a automatic necessity of an ART line, but that is one of the markers of volume responsiveness, is using all of the things like pulse pressure variation or increase in MAP. All right. Any other questions? I know we're over time, Apoorva. Are we going to continue with those last questions, or do we call it a day?
Yeah, if you're okay with it, I'm just going to ask you.
Yeah, I'm fine with it. Yeah.
It's not something related to the trial itself. So one of the questions we got from the audience, even before we started, was what's one resuscitation practice that most emergency physicians still do, which you believe causes more harm than benefit?
Ooh, that's a great question. Let me think about that one. One thing we're still doing that's more harm than benefit. I mean, honestly, and it's related to this trial, I think following surviving sepsis campaign guidelines is across the world a thing that's really harming patients. I think. I don't think those guidelines are good. And I did multiple episodes explaining the reasons why. And I think that group means well, but they're not adapting. They are really stuck in a early goal directed therapy organized world that really we should have gotten rid of like 15 years ago.
Fair enough. One of the reasons so many people, listen to EMCrit is that it consistently challenges established thinking and dogma. What do you think? Why do you think medicine so often develops dogma in the first place?
I mean, dogma means you're in a safe place in the pack, right? Like if you're following dogma, then you're probably doing what a majority of people are doing, and therefore your practice is safe from commentary, right? Like, the dogma that like came to mind most recently from my last shift was when the renal fellow came down and they were angry that we gave lactated ringers to a patient with hyperkalemia, right? And that's dogma. Dogma is you don't give lactated ringers to these patients because it contains potassium, right? And so if that renal fellow writes on his consult, give normal saline to this patient, he's never going to get yelled at by his attendings unless the attendings are also in a space of dogma-lysis, right? That's that's standard care. It's bad care. It's wrong care. We have trials from the renal literature showing that it makes the hyperkalemia worse than lactated ringers because it induces acidosis, which causes further shifting of the potassium. But that would require, first of all, this fellow to be incredibly up to date. He would have had to read all the literature. Most people are not reading the literature. They're going by what they learned in residency and fellowship or what they learn at the one meeting they go to every 2 years, right? Like that's their level of change in their practice. And it would be like when you give lactated ringers, it's a real slap in the face of the establishment. And people are going to comment just like he did. You now are going to get the renal chair, if he has not stayed up with the literature, writing you emails saying you're killing these patients. What are you doing? And then you have to fight. And most people don't want to fight. They just want to practice and they want to go home and they want to relax. They don't want to fight. So that's why, because breaking with dogma is a pain in the ass. It makes your practice more interesting, but also more fraught and more difficult. And you have to have like a lot of discussion, and you have to be willing to, you have to have the capability of having conflict. And most people don't want that. Like they don't like conflict. You have to now tell the renal fellow, oh, I'm so sorry. I know where you're coming from. I would have been in the same place 10 years ago, but here's the literature from your own field, right? It all comes from the renal field. Here it is. Maybe what you want to do is read those papers and come back to me. And if you still feel I'm wrong, then I'm happy to have that discussion. Most people don't want to do that. Like that butting of heads is very, something they want to avoid. It's not enjoyable for people to have conflict. So if you stick with the dogma, you don't have as much conflict.
Great. I know many of us, this we've kind of partly covered already. Many of us learn facts, guidelines, and protocols, but how does one learn to think critically about evidence?
So, getting good at actual study interpretation is important, but I don't think as important as I would have said 20 years ago. What I want to tell you now is the better thing is to find people good at that and use their interpretation. So what you want is someone vetting the studies, and that could be someone within your own department, or it could be, someone, in the various foam worlds, or, the critical appraisal things they do on major papers, like the bottom line is fantastic for critical care type papers. So take trials that are already vetted by someone. Like I was going to do evidence-based medicine as part of my niche and realized like, A, I don't love it, and B, I'm not as good at it as other people. So I don't even do the study interpretation. I have like friends like Josh Farkas, my partner in crime, and other people. I let them do the evidence interpretation. And then the next step of critical thinking about studies is, okay, great. My buddies or someone at a national level said this study is good, but is it clinically useful? Is it actually applicable to my patients? Is it doable? And that's the stuff I really want every emergency physician to be thinking is like, all right, there's this new trial. Great. So if you have like every resource in the world and all sorts of money, you could do it. But is it good for my practice? And that's only you know that, right? Or only your department knows that. So that's where the level I'd love people to be saying, like, okay, so Scott's saying ANDROMEDA-SHOCK-2 is interesting. He's talking about all this stuff. Are we actually going to do it at the bedside, right? Like, so the person who asked about the cap refill time, about the generalizability, that's a good question, right? Like, can we actually get this done in our place? Yes, no, maybe. Can we do volume responsiveness in our place? Yes, no, maybe. Those are the questions I want you thinking critically about, right? Like, is this better than our standard practice? Yes, there's an evidence-based trial saying it, but are we ready to make the change, right? Like, that's the kind of stuff I'd love ED physicians to talk critically about. And, we have a lot of, in residency and in training, we have a lot of journal clubs that are focused on the evidence side. I think what you've done here is so important to have journal clubs focused on the clinical side. That's the kind of critical thinking that I think we should be doing.
Amazing. If you could teach every emergency physician in the world one skill tomorrow, what would that be?
Okay, well, this is not going to be what you think
one.
I'm going to answer because, this is going to be my coaching hat. But I would teach them self-compassion because we have a real epidemic of burnout going on, at least in the United States. I don't know how it is in India, but people are pretty miserable after COVID. And like a lot of it, yeah, it's the practice, but it's also their own internal mindset. And people are really hard on themselves. It's what allowed us to get through our medical training. It's allowed us to jump through all the hoops of testing and winnowing out and all of that other stuff that got us where we are. And then those same habits continue to exist. And as a result, we're super hard on ourselves. We're miserable and we're brutal to ourselves. Our inner voices are really mean and criticizing. So learning self-compassion and learning how to treat ourselves nicely and kindly, I think would be the skill I'd want every emergency physician to learn.
That's a brilliant answer. I never expected that this would be the answer. I didn't have an expectation of what would be the answer, but never really expected this would be the answer.
Yeah, it's funny. People like the EMCrit, there's always people, if I put stuff about this on EMCrit, really get taken aback and they don't like it. So I've done that stuff more outside of the podcast with coaching individually or group coaching practices than I do on the podcast. So people who only listen to the podcast, they're not going to see that side of it. But it's probably one of the most important things we could do.
No, I totally agree. I think if I remember correctly, I think your last post was something about compassion in medicine. And
yeah, we had Steve Treziak on
group as well. And I'm yet to go through that completely, but I read few of the links you had given there. So they were great as well.
Thank you. And that's primarily, that podcast was on compassion for our patients. And so that's why I say we also need to have compassion for ourselves. And that wasn't discussed on that podcast. We need both. We need compassion for our people we treat, but we also need it for the person who actually is doing the treating.
True. Last two questions. What do you think are some of the recurrent cognitive traps or mistakes that you see clinicians making in resuscitation?
There's so many. If you look at Mind of the Resuscitationist on EMCrit, you'll find all of them. I'll give you just one that I think is really prevalent, which is what I call BIDGO, BDGO, which is bad decisions, good outcomes. And it's so prevalent in emergency medicine. The case went okay. The intubation went okay. And everyone's slapping them high fives and everyone's happy. But we actually review the videos of the intubation and you look at it and their skills were horrible. Like they never actually got into the vallecula with their Macintosh blade. They only were able to get the tube in through luck. You had like the tiniest glimmer of the very posterior portion of the cords, even though if they had just lifted a little more, they would have had 100% cord visualization. That is bad decision, good outcome, or bad technique, good outcome. And the problem is that since there was a good outcome, it reinforces the bad behavior and makes the person even more likely to do it the wrong way next time. So we have to really analyze that. And when we do case quality assurance, what we look for is, the patient did okay, but the care was kind of crap. And they were just lucky that the patient did okay. That's the cognitive bias you really have to be aware of.
Yeah, that's true. The final question, I know you've been doing this podcast for a while. After all these years, what still makes you excited to read papers and record podcasts? What keeps the curiosity alive?
All of you. because it means that, I get to talk to the smartest people in the world about it. I get to make a clinical stance for how I think is the optimal way to care for my patients. And then I get to hear back from all the listeners about all the ways that I missed it and I'm wrong. And then that makes my practice better and better. So this is incredibly virtuous cycle where I get to figure out, based on the best available evidence, what is the way I want to treat my patients tomorrow when I go on shift. And then instead of just that being my practice, I am in the incredibly lucky position of hearing back from thousands and thousands of people about their opinion on how to make that care even better.
Thank you. Thank you so much. All right, that brings us to the end of the session. Dr. Weingart, before we conclude, I just want to thank you once again. Thank you for the generosity with your time. Thank you for your commitment to education. And thank you for continuing to challenge all of us to think more deeply and read more critically and care for our patients more thoughtfully. Our vision with LitEM is simple, to bring together curious clinicians, important ideas, and outstanding educators from India and around the world. Actually, a few weeks ago when we were ideating this, Dr. Rahul Katar, Group Lead for Emergency Medicine at STAR, Dr. Rakesh Ataluri, our academic lead, and I were discussing who should we invite for our inaugural LitEM session. And, sorry? Did you say something?
Yep.
Okay, sorry. So we were just discussing who should we invite. And then, jokingly, we said maybe we should try Dr. Scott Weingart and send him a cold email. And we just did. But to our surprise and to our delight, Dr. Weingart replied and agreed. And I think we couldn't have asked for a better start to a project than this. So thank you so much once again. This is the first episode. Every month, we hope to host experts from across the globe, discuss landmark studies, how it translates to clinical care, challenge assumptions, and explore the evolving science of medicine. Thank you all of us. Thank you all of you for joining us today. And stay curious, keep questioning, and we'll see you again in our next session. Until then, take care. Dr. Weingart, thank you so much once again.
Such a pleasure. Bye-bye, my friends.